Okay, good afternoon, everybody. Can you hear me okay?
Yes, we can.
Good. Okay, now delighted to be part of this pop-up, and I think it's providing a great opportunity to connect in with colleagues, hear about some of the changes and I suppose learning that's going on. And I think I would echo a lot of what Richard has said about how we can maximize, I guess, the opportunities this challenge has brought to look at some sustainable solutions. So my name is Margaret Whoriskey, and I'm responsible for the National Technology Enabled Care Programme in Scotland. And I'm really going to just talk a little bit about what's been happening over the last few weeks in terms of rapid scale up, and using an example of our Near Me Attend Anywhere video scale up as something to draw out, I think, why we've been able to do what we've done. Next slide. So in reflecting really on our ability to do a rapid scale up, and I'm talking about doing something in weeks rather than the plan would have been a number of years, I was reflecting on what some of the conditions were that supported that. So on the policy side, we've had a clear policy around technology enabled care since 2015. We published our digital health and care strategy just under 2 years ago, and that again reinforced the importance and the role and contribution of a range of technologies, including VC, to support access. We have our realistic medicine, which is very much about personalising care and health, and that also talked about the role digital can play in terms of facilitating greater control and choice for citizens. And also the work we are doing was set out in our Scottish budget. So quite a strong policy context, and that was supported by a strong programme. So building on some earlier work that was done around video consulting, the tech programme provided funding for early adopters and some of the national work required. We procured the Attend Anywhere platform in 2018, and that's been what we've been using. And I know other colleagues in England and Wales have also been using Attend Anywhere. And in 2019, we provided some funding to all our health boards in Scotland. So we've got 14 territorial health boards, and also some support and change management to support implementation of Near Me. And again, back that up by undertaking an evaluation, which was progressed by Trish Greenhow from Oxford University and is just due to report. Next slide, please. So business as usual in normal circumstances. This was a chart that we set out in a paper that I took to our tech board in February, so not that long ago. We had approximately over 1,000 consultations a month using our Attend Anywhere platform. And by March 2021, we were aiming for shifting that to 3,000 a month. That was still seen as being reasonably ambitious, although still a very small percentage of all consultations. But we were taking an incremental improvement approach to this, looking at how we'd extend into primary care and also social care, as well as some of the outpatient and hospital work that was done. And from our experience, we saw that from initial tests of change through to development phase, preparing for scale up, at scale adoption and business as usual, we were looking for about 3 years. And the example here was given as Highland, who'd been working on this for a number of years, and they saw that they were moving into that at scale adoption, but that was after 3 years of work. Next slide, please. So why Near Me now? So we're using Near Me as the name of our program. As I say, it's supported by the Attend Anywhere platform. So sometimes Attend Anywhere is used as well. So why was Near Me seen as being a particular opportunity as part of the response to COVID? Well, firstly, to reduce exposure for patients and other patients in practice, as well as clinicians, to undertake consultations for people experiencing COVID symptoms, for continuity of normal and priority services, to enable home working, and that's also been supporting clinicians who've had to self-isolate. They've been able to continue some of their work, to provide some decision support and to provide resilience. We've also been doing work recently with care homes, and again, that's been receiving a lot of attention in Scotland as well as elsewhere in the UK around some of the significant challenges we have with our very vulnerable population in care homes. And we've also been doing work with our prisons as well as our health services. Next slide, please. So you can see that this graph is showing a significant increase in consultations. So remember back, I was saying we had about 1,000 consultations a month happening in February, and we were aiming for 3,000 a month by March 2021. You can see that last week we had in excess of 9,000 consultations in 1 week. So, you know, we've seen huge growth. We've also seen a big growth, particularly in primary care consultations. We have rolled out guidance across primary care and secondary care services. We have been working with colleagues in our improvement organisations to support the local practice on the ground. We've been working to ensure that primary care and other services are equipped with the technology required, which is not overly sophisticated, but they need to have a good internet connectivity and they need to have a webcam. You can use your own device as well. So I think we've been trying to encourage people not to see the actual equipment as a barrier, but actually clinicians can use their own device if there isn't an appropriate device available. Next slide, please. So what made the difference in terms of moving from that sort of slower, more normal, I suppose, way of incremental scale up that, as I say, was going to take us a number of years probably to get the coverage we're getting right now. So I think, as Richard has articulated, digital interventions are now seen as of critical importance by all. And we were given a very clear mandate from our health minister right through to our policymakers and senior officials to extend the near me approach to all primary care services and secondary care in a matter of weeks, not years. Within secondary care, we've identified 7 or 8 key priority specialties, but we're also recognising as we move through the emergency phase into the recovery phase, we have to also be able to look at how we respond to the unmet demand. I mean, a lot of elective work, if not most elective work, has been cancelled in Scotland, and it's how do we begin to address some of those needs as we move out of the emergency phase. We were able to undertake a speedy procurement, and we were able to use emergency procurement to do that, to extend our platform significantly, to be able to cope with the additional demand, and also, as I say, getting our GP practices and other clinics equipped. I think our ability to scale up was based on a lot of the work that had gone on in the previous few years, where we'd addressed a lot of the barriers at national level and also been working with all our local boards, even though it was small scale, but there was local capability within local boards in terms of being able to take forward this work. As I say, training, practical support and evaluation. I mean, all of these, I think, have helped create the conditions for a rapid scale up. We've seen redirects of staffing resources from wider primary care and secondary care improvement programmes. Something like 50 staff were redirected from routine primary care improvement work to support the near me scale up. So that wouldn't have happened in normal circumstances. And there will be something we have to address about how we sustain support going forward. We've done quite a bit of work as well on our comms and communications. There's been some public awareness done with the local public, as well as working with our various professional groups. And there's a real accountability for delivery. So this is not in the nice to do box anymore. This has actually been seen as something that's really required to be delivered. There are still some issues that we're working with. So, while GP practices have basic equipment, it's not in every GP's room. If a GP starts with a telephone consultation and wants to move quite swiftly into a near me consultation, there needs to be a log on for that. So we're trying to look at how we can streamline that process so it makes it easier for the GP or clinician to do that. We're still working on that clinical leadership and engagement across the specialties. We've a lot of interest from our non-health colleagues as well. As I say, we're working with care homes to try and improve access also. So we've a lot achieved in a few weeks. I think the real opportunity is how do we sustain some of this or a lot of this as we move into that recovery and renewal phase that Richard has talked about. So that's a very quick example of some work underway in Scotland.
Thank you for that, Margaret. That was fascinating. There's a phrase in English that we use, which is this is exactly what it says on the tin. Before you go, I think we wanted to have a really good example of existing technology, and that's nailed it in one. So thanks for that. I'm conscious you've got to leave before we do the Q&A session at the end. What I would like, we've got a question in, and I'm going to push all the questions towards the end. It's from Brian O'Connor, asking this is a really good example of practical deployment. Do you think this will be the new normal?
Yeah, I mean, I think it will be the new normal, and it's interesting. I've had a few sort of anecdotal examples of, you know, in interactions, nothing to do with work. I mean, one was on an online Pilates lesson, and there was somebody talking about their work, what they were doing, and they said, "Oh, we're using this near me technology, which is great because we're able to work and with our patients, and the patients really like it." So I think people are beginning to really engage with it. It's not suitable for everything, and I think we need to be clear around, you know, the range of approaches that need to be adopted. But I think we will see this as becoming much more integrated in the way people deliver services and the way I think citizens expect to now access you know, healthcare interventions and support. As I say, I think there's still a bit of a challenge to how we keep the momentum and the focus and the sustainability as we go forward. We need to be able to address any barriers that come up, be those technical or be those sort of process or change management barriers. We need to keep that clinical leadership and engagement, and we need to keep the public engaged in a constructive way around the opportunities that this provides. So as I say, I think we've a lot learned, and I think a lot more to do.
And it'd be interesting to see how much demand there is from patient groups and citizens, because I for one recognise that, you know, would I want to go back to the old ways as a consumer of health and social care? I'm going to take advantage. We've got a couple of questions coming in, and I'm not going to do this for us, but just obviously with Margaret coming to leave, do you allow? This is a question from Laurie Hawkins from Australia. Hello, Laurie. Do you allow different services such as dietitians of pharmacy, etc.? And do you have a national director of services on telehealth?
Yeah, I mean, there's a whole range of services that have begun, that had already engaged with our Attend Anywhere Near Me, and obviously Attend Anywhere has come from Australia. So there are a range of allied health professional services that are also engaged with it, pharmacy examples as well. As I say, there's increasing interest from non-health services as well. We've done some really interesting work with rape crisis centres, you know, working with people who are not digitally connected. So I think that's one of the issues, that in Scotland we still have people who you know, don't have a device, or even if they do have a device, they're not able to access internet on a regular basis, or don't have data on their phone. So we are looking to see how this can be seen as not a charged for service. So I think there's an interesting programme in Scotland that's been called No One Left Behind, and it's really trying to address this issue of digital exclusion. Yeah. Because it's fine having services like Near Me, but if we're going to further disadvantage some hard to reach groups, you know, we need to be able to address that. So I think it's been used in a whole range of areas, and obviously our focus is more now in the emergency, but it's about around how we extend that going forward.
And I'm assuming, just thanks for that. I've also seen we've got a question from Adam Giangreco here. Do you have? I mean, would you have data to say, well, these are the numbers we're getting now? Obviously, you've got those for how many people are using Near Me, but then compare that with numbers who would be seen in face-to-face consultations as well. I'm not asking for the figure, but do you have that sort of level of data?
Yeah, we certainly have good secondary care data in terms of all the numbers of people that are seen in various outpatient clinics, and we have the near me data now, which is beginning to track clinics, hospitals,
Mm.
GP practices. We probably don't have as good information around the primary care and community services in that way, and I think we're not currently collecting um, nationally the number of sort of telephone calls, for example, GPs are making, although we know that, the vast majority of interactions at primary care are now starting with a phone call, and people are only being seen face to face if that's considered required. So we have reasonable data, but I think there's more granularity that we probably can develop in terms of,
Okay.
of this going forward.
Interesting. And thanks for that. And thanks for the questions as well.